Hello, everyone. My name is Dr. Abhijnan Maji. I'm an internal medicine specialist working in the hospital in Kolkata. I'm attached as a senior consultant in Bellevue Clinic, Kolkata, and Techno Global Hospital, Barakpur. I am specialized in internal medicine, but I have a very special interest in diabetes and metabolic syndrome. So today we are going to discuss a very interesting case study, and this is about a 45-year-old man who is newly diagnosed with type 2 diabetes, who visited the clinic 6 months back with the multiple risk factors like obesity, hypertension, hyperlipidemia. And he was initiated with metformin with advice for lifestyle and diet modification. Recently, he visited again as part of routine checkup. His laboratory workup showed parameters as following. Like HbA1c on presentation was almost 8.5%. The eGFR was around 80. His LDL level was 80 milligram per deciliter. His HDL was 38. Triglycerides was around 200. So he presented with a very high HbA1c level. And because he's a newly diagnosed one, and he's a quite young patient with dyslipidemic changes. So we started on medications initially as a metformin 1000 milligram twice daily with an AC inhibitor, lisinopril 40 milligram, then metoprolol with 100 milligram, and a statin 40 milligram, and an aspirin. So we started with a metformin, an AC inhibitor, and a beta blocker, cardioselective beta blocker, a statin, and a blood thinner. Now, his BMI was around 31, so it was high. His BP was around 120/70, heart rate was around 78. Now, the evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of the microvascular and the macrovascular complications in type 2 diabetic patients. And that we know from the UKPDS trial. And the UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was apparent, even though no difference in HbA1c levels between the intensive and conventional therapy. So when metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, the initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline HbA1c level. And early combination therapy in type 2 diabetic patients makes clinical sense for the several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target, that is HbA1c below 7%, compared with metformin monotherapy. For patients with HbA1c more than 1.5% above goal at diagnosis, both ADA and EASD guidelines recommend the first-line treatment with dual combination and an SGLT2 inhibitors as a first post-metformin treatment in patients with established cardiovascular disease, congestive cardiac failure, and or chronic kidney disease. The empagliflozin and linagliptin combination with complementary mechanisms and pleiotropic benefits may be suitable option across a range of patients, including those with established, cardiovascular disease or high-risk patients, and if there is established heart failure or chronic kidney disease patients, due to the tolerability of the combination, in addition to the potential benefits of empagliflozin on cardiovascular and renal outcomes, and no increased risk of heart failure with either agent, that is not by the empagliflozin or linagliptin. So according to the study, the early achievement of HbA1c goal, that is less than 7%, with Impalina combination could reach target HbA1c at 12 weeks compared to the monotherapies. So the HbA1c levels decrements by the Impalina combination has demonstrated 1.81% HbA1c reduction at HbA1c base level more than 8.5 at 24 weeks in metformin treated groups. And the benefits on the glycemic control was maintained at week 52 in metformin treated groups and a higher percentage of patients achieving HbA1c level less than 7% were reported for combinations. And the combination offers a suitable component in strategy to achieve the target HbA1c level without increased risk of hyperglycemia and weight gain, with improvement in overall lipid profile, a reduction in the incidence of genital infections associated with these SGLT2 inhibitors have been reported. But when a DPP4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remains to be investigated. So in summary, the Empalina combination provides the robust HbA1c reduction, 2 to 4 times higher odds of patients reaching the goal of HbA1c compared to the individual agents with low hypoglycemic risk. Thank you very much.